Hello, good evening, everyone. Hope I'm audible. So, audio, video, I'm considering everything is clear. So, how are you people? So, yesterday we had one session, right? Remember, it was about the congestive cardiac failure. So, yesterday we discussed a lot about congestive cardiac failure, which included your pathology aspects, which included your aspects from the medicine, and main target was on the pharmacology. So, like that only, today also we are going to do the same approach, but we are going to learn about angina and hypertension, right? So, when we are speaking of angina and hypertension, so let's start first and most important with the angina. Let's start with what is that angina. Okay. So let's start with the angina. Now, when we are speaking of angina, the first question is, so what is angina? As soon as we ask what is angina, every student with full confidence, they tell only one thing. So the patient is having chest pain. The patient is having chest pain. Well, patient having a chest pain is a feature of angina, but there is a little more to it which you are supposed to add. So angina is a chest pain. Of course, that is chest pain. It is caused as a result of what? It is caused as a result of angina is a chest pain. Angina is a chest pain due to what? Due to decrease of blood supply. Due to decrease of blood supply to the heart. So whenever blood supply is reduced, automatically what will happen? Your chest pain can occur. So remember, anytime if blood supply is decreased, so the organ is going into ischemia, that is lack of blood supply. So when there is a lack of blood supply, that will lead to first clinical feature. You can call it as a pain. So pain is one of the common feature whenever there is a lack of blood supply to any organ that can occur. But here in the chest, what will happen? There is a lack of blood supply. So that is what is causing what is that? Angina. Now when we are speaking of angina, the question comes to us is what? So when we are speaking of angina, what is the main problem here? The problem in the angina is very simple. There is a increase of demand of oxygen, increased demand of oxygen, increased demand of what is that? Oxygen, or there can be decreased supply of oxygen, decreased supply of oxygen. So this is a two important statements. What are the two important statements? Remember, that is your lack of blood supply and your heart is demanding for more oxygen. So when will your heart demand more oxygen? So when your heart will demand more oxygen is the time whenever you are doing some physical activity, your heart has to contract more and your force of contraction will increase. So once the force of contraction is increased, the heart will demand for the more oxygen. So increase of demand occurs as a result of what is that? Result of physical activity. So whenever we are looking at angina, the most important question comes to us is types of angina. What is the question comes to us? Types of angina. So types of angina, let's discuss one by one. Let's discuss all the in and outs and then we will go to the rest of it. Okay. So whenever we are speaking of angina, sir, the first type of angina which everyone must know is called as stable angina. Is called as stable angina. So stable angina is a condition. What is there? There is a chest pain is there, but remember chest pain will be there, but pain will be there. That doesn't mean it will be present all the time. But when will the pain come is the question. So pain due to physical exercise, due to physical activity, due to what? Physical activity. Okay. So you are doing a physical activity. Because of the physical activity, what is there? Pain will be there. So after physical activity, always remember there is no pain at rest. Whenever patient is happily sitting at his home, patient is not doing any work, definitely there is no problem. There is no problem. But whenever he does the physical activity, patient will have a pain. That pain can be relieved by one of the most important statement. Everyone will tell pain at rest, pain at rest. Yes, you can get the notes. We'll update it in the group definitely. Okay, now listen to me. Pain at the rest, and remember pain is relieved also. Okay, pain can be relieved by two important factors, by decreasing or by rest, by decreasing the physical activity, that is by rest, or you can also decrease the pain by using of nitrates, so if this case scenario is present, then we will call it as a stable angina. Stable angina. What is stable angina? Very simple. The patient is having what is that? Pain at Very important, physical activity. Okay, so this is a story of your stable angina. Now stable angina mostly associated with what? Coronary artery disease. What is that? Coronary artery disease. So what is this coronary artery disease? Coronary artery disease is a atherosclerosis in the coronary arteries. Okay, so this is your, what is that? Stable angina. So when we are looking at a stable angina, let's take and understand about what happens in the blood vessels, right? Consider this is one artery. Consider this is one artery. Now inside the artery, all of you know coronary artery disease means what is there, sir? Yes, there will be a plaque will be present. Of course, atherosclerotic plaque. Now atherosclerotic plaque is there, okay, and the endothelium is sitting like this. Atherosclerotic plaque is there, endothelium is sitting like this. Now easily coronary blood flow is occurring. Easily what is occurring? Coronary blood flow is occurring. But when coronary blood flow is occurring, though there is a lumen will be open. But whenever our patient does the physical activity, right? Physical activity he will do. As soon as he does the physical activity, the problem will arise. Automatically there is an increase of demand. Yes, there is an increase of demand. But look here, at rest, no problem, because still the blood supply is intact. But when he does the exercise, automatically what will happen? Increase of demand of oxygen. As there is an increased demand of oxygen, and the lumen is small now. Why lumen is small? Because one important point, at rest the demand is less, but at physical activity demand has increased. If the demand has increased to supply, now this lumen will not be sufficient. If this is not sufficient, it will lead to what is that? Chest pain, called as angina. Okay, chest pain leading to angina. So this is your, what is that? Stable angina. Let's go to the next important, called as unstable angina. What is that? Called as unstable angina. What is that? Unstable angina. Now when we are speaking of unstable angina, my dear students, these unstable angina, what happens? There can be pain. There can be pain even at rest. Pain even at rest. So pain even at rest, it is not precipitated by what? Not precipitated by physical activity. Means patient can get the pain even at the rest. So what is exactly happening inside unstable angina? So let's see what and understand. So consider this is a blood vessel. Now already I told you people, there was what was there? There was a plaque which was present. Yes, of course, coronary artery disease and a plaque was present. Okay, now once there is a rupture of this plaque will occur, when there is a rupture of this plaque will occur, automatically what will happen? So rupture of the plaque will occur, it will cause the clots to form. So now what will happen? There is a thrombus or clot is been ruptured. During this time the blood supply will be impaired or lost. If there is a lack of blood supply, patient will get a chest pain. That is only unstable angina. Unstable angina, even the patient is having a pain at rest. So this is the story of your unstable angina. Once we understood about unstable angina, let's talk about the next important aspect. There is something called as a variant angina. What is that? Variant angina. Variant angina is only, you are also known as a Prinzmetal angina. Is also known as Prinzmetal angina. What is that called as? Prinzmetal angina. Prinzmetal angina. So when we are speaking of Prinzmetal angina, the question comes to us is, what is Prinzmetal angina then? Already you told us, sir, both of them are due to coronary artery disease. But coronary artery disease, what is happening? Yes, very important. What is that? The plaque was getting ruptured. That was causing a unstable angina. Now remember Prinzmetal angina. Now Prinzmetal angina, my dear students, it is due to vasospasm. It is due to vasospasm. Okay, so this is a very important. The patient will have vasospasm. So this vasospasm will be, what is that? Whenever blood vessels are contracting, the patient will have pain. Now you might ask me, sir, will there be coronary artery disease or no coronary artery disease? Usually no coronary artery disease in a CAD patient. No coronary artery disease in which patient? Coronary artery disease in Prinzmetal angina. And most importantly, remember, it is usually common in night, usually nocturnal, but there is no mandatory rule that always occurs in the night. It can occur in both day and night, but it can occur in the night more commonly. And remember here, no vasospasm, no CAD, usually nocturnal, and most importantly, this Prinzmetal angina is a episodic scenario. Okay, episodic scenario means sometimes there is few minutes the patient had angina, but after a few minutes angina has been disappeared. So like that type of angina, we would call it as a Prince metal angina. We'll call it as a Prince metal angina, or also called as variant angina. So unstable, stable, and variant angina. Sir, why we must know these three types of angina? So remember, these three types of angina will guide us through what is the treatment, because you cannot blindly give for every patient, you cannot give similar drugs. So for each patient will have a different type of treatment. So that is why we must know this. Okay, then the next question comes to us is, sir, okay, we understood about this angina, but the next important, what about the pathological changes? Remember, pathological changes, usually myocardial necrosis will occur in the myocardial infarction. Here there is no necrosis yet. It is no necrosis yet. Okay, so remember, there is no necrosis, no necrosis of myocardium. So if there is no necrosis, there is no infarct. If there is no infarct and no necrosis, automatically cardiac markers will be negative. What is that? Cardiac markers will be negative. So you people write down the cardiac markers. So write down the cardiac markers. What are those cardiac markers? Very good. One is your troponin. What is that? Troponin. Okay, apart from that, there is something called CKMB. What is that? Creatine kinase MB form, creatine kinase MB form, and also your LDH1, and also you have your, what is that? That is your myoglobin, which is not specific to heart only, but it can be present even in the rhabdomyolysis. But most specific ones are troponin, CKMB, and LDH. These are your cardiac markers. So cardiac markers, what will be there? Will they be positive or negative? So in the blood sample, if you take and look at the patient, so automatically remember, they're negative in angina. They're, what is that? Negative in angina. They're negative in angina. So this is a very important question. What is that? Cardiac markers. Cardiac markers will be present or absent? Very importantly, absent in angina. Cardiac markers will be absent in angina. Now, please understand, what is the pain characteristics, or where does the pain occur? Pain occurs usually, this is a chest pain, right? So chest pain, if it is occurring, the most important thing is left sided chest pain, left-sided chest pain. Okay, which will further radiates towards what? Which will radiate to the shoulder, left shoulder and the left arm. Okay, radiate to shoulder and the left arm, shoulder and the left arm. Okay, now there is no rule that it will always radiates to the hand. So if patient comes to you with the chest pain, the first and most important thing you need to do is what? Understand the characteristics, then do a ECG and rule out the cause for the chest pain. That is most important thing. Now apart from that left sided chest pain, what else patient can have? So these people can also have pain, the chest pain that can even can radiate even to the jaw, right? So even to the jaw. So if somebody comes, sir, I'm having discomfort here, now you will tell, hey, that nothing will happen, go. Okay, after 1 hour you are turning and seeing the patient is dead because of MI. Okay, so remember, you cannot neglect some pain. So the pain can even radiate to the jaw. Okay, pain radiates to the jaw. Okay, all right. So once we understood about this, the next important aspect, what we need to know, ECG changes, my dear students. What are the ECG changes we can find? So in the patient with angina, what are the ECG changes we are going to get? Let's start with one of the most important, that is your in the stable angina. In the stable angina, in which angina? Stable angina. So whenever patient is at a stable angina, most of the time we can find something called as significant Q waves, but only patient will have Q waves. But whenever this patient gets the angina, that time there can be different waves. Okay, so stable angina, Q waves. When we are speaking about unstable angina, so there's more specifically unstable angina. What we can see is that, remember inverted T waves. What is that? Inverted T wave. Inverted T wave. Now everyone will tell me, sir, first sign of myocardial ischemia is inverted T wave only, right? Yes, you are right. But even before that, even earlier, even before T wave, the most important ST segment suppression. What is that? ST segment depression or suppression. Write down ST depression can be seen. So ST depression will occur as a result of even what is that? Ischemia and angina. So what are the changes we can find in the ECG for a patient with angina? Q waves, right? Inverted T waves and ST segment depression. ST segment depression also suggestive of what is that? Angina. Even earlier, even the earliest. So in your MCQ, if you get ST suppression, that is the earliest. After ST suppression, T wave inversion will be seen. Okay, so do not make a mistake. Many students argue that no, always the first one is inverted T wave, even way before that ST segment depression. Remember, ST segment depression, whenever it is occurring, so this is due to what? This is due to subendocardial ischemia. This is due to what? Subendocardial ischemia. What is the speciality about this subendocardial ischemia? So the speciality is that whenever there is an angina, the first area to undergo ischemia is subendocardial region, because this is the watershed area in the heart. This is the watershed area. Watershed area means the area with a less blood supply. So subendocardial ischemia. Subendocardial ischemia. So the first sign is ST depression, then inverted T wave, then also you can get a Q wave. Then the patient will have, oh my God, my heart is paining, right? So your heart is paining because of what? A lack of oxygen. Okay, so that is the story of your what is that? ECG changes with the angina. So when we are speaking of angina, so what are the investigations we can do? So we can do investigation chest X-ray, not greatly useful. ECG is the most important. And remember your cardiac markers. Okay, always we are supposed to do a cardiac marker. If cardiac markers are positive or negative, we need to see. So if cardiac markers, if you check, if positive, then automatically it is a case of myocardial infarction. If negative, yes, it is a case of angina. Now you can ask me, sir, what about in the EMI? Yes, ST elevation can be seen. ST elevation. So here also first ST depression, later it can proceed into ST elevation. ST elevation, even if it is there or not there, because in cases like N-STEMI, non-ST elevated MI, what can happen is that ST elevation may not be seen. Even if it is not be seen, still if cardiac marker is positive, that is the absolute diagnostic factor for making a myocardial infarction as a diagnosis. So this is a story of your stable, unstable and cardiac markers with respect to that of angina. So once we understood about all this disease itself, then now we are going to face towards what is that? The anti-anginal drugs. What is that? Anti-anginal drugs. Okay, anti-anginal drugs. Anti-anginal drugs. So when we are speaking of anti-anginal drugs, my dear students, there are three major groups of drugs which are used in angina. Three major groups of drugs. So for chest pain, what you are supposed to take? Anti-anginal. So what are the anti-anginal drugs we have? The first and most important, the old anti-anginal, I can say, from long age, we are using these drugs, that is your organonitrates. What are they were? Organonitrates. So we have organonitrates. So that is your anti-anginals, organonitrates. So when we are speaking of anti-anginal, apart from that, we can also use, my dear students, beta blockers, and we can also use what is that? Calcium channel blockers. We can also use what is that? Calcium channel blockers. So these are the three major groups of anti-anginal drugs are there. So apart from that, we have other newer agents are there. So what are these newer agents? Newer agents is your ranolazine. That is your what is that? Ranolazine. Then we have one more drug called as a trimetazidine. What is that? Trimetazidine. What is a drug? Ranolazine and trimetazidine. Okay. Apart from that, you also have one more drug called as fascudil. What is that? Fascodil. Okay, so many students tell me that, sir, how can we remember Fascodil? So Fascodil, we can remember it like dil is there in the, yes, dil means heart, right? So in Hindi, dil means heart. The drug itself has a dil in the ending. So why this drug is that much confusing? Because this drug belongs to a group called as rho kinase inhibitor. Now we don't have many rho kinase inhibitor. The only one available is with Fascodil. So because of this reason, we tend to get confused. Hey, we didn't hear any similar ending drugs, right? So that is why don't get confused. Fascodil. Okay. So this is other story of your anti-anginal classification. So among these anti-anginals, let's start with the first group of drugs. What is that? Organonitrates. What are they? Organonitrates. When I'm speaking of organonitrates, my dear students, hope everything is clear so far. Everybody able to understand? So when we are speaking of organonitrates, let's talk about organonitrates. We have some drugs such as isosorbide. What is that? Isosorbide. So these isosorbide also have types called as mononitrate. Isosorbide mononitrate. See, isosorbide, if used individually, isosorbide mononitrate is a full name. If used individually, it has a diuretic effect. Actually, isosorbide has a diuretic effect. Then we have drugs such as nitroglycerin. We have drugs such as glycerin. So this is a very popular drug, shortly known as NTG. Apart from nitroglycerin, we also have such as sodium nitrate. What is that? Sodium nitrate. Apart from sodium nitrate, we have also one more drug called as sodium nitroprusside. What is that? Sodium nitroprusside. Sodium nitroprusside always manufactured in a amber color bottles. Why? So this is a fun fact. Remember, whenever sodium nitroprusside, if it is exposed to sunlight like that only, it will break down and destroy the drug. So to prevent that from happening, we manufacture it in, what is that? Yes, it is manufactured into a amber color bottle. Okay, so like that only, there is one more drug in your central nervous system. If you can find out and put it in the comments, let's see. Okay, then this is your sodium nitroprusside. So these are the drugs which are used for the angina and other conditions also. Okay, so there is one more thing. There is something called as sodium thiosulfate. We'll talk about sodium thiosulfate later. Okay, so this is a story of your nitrate. So whenever we give nitrates, everybody knows one thing, sir, nitrates will cause vasodilation, so no problem. Nitrates will cause vasodilation, so blood supply will be improved. Half of the time you are making a blunder mistake there by saying this, because that is not the main mechanism through which organonitrates work. So then what is the mechanism? Okay, now follow me. I'll tell you people, very easy to understand. Whenever we give organonitrate, what is that? Organonitrate. So these organonitrates, my dear students, come inside the body. Once they enter the body, they undergo the effect of one most important enzyme. What is that? That is only called as mitochondrial aldehyde dehydrogenase. Aldehyde dehydrogenase. Mitochondrial aldehyde dehydrogenase will convert organonitrates into, my dear students, NO. Now NO, all of you know, it is called as nitric oxide. Sir, nitric oxide, once it is formed, what will happen? It will go and act upon the smooth muscles. Cell. So once it act on the smooth muscle cell, what will happen inside the smooth muscle? Consider this is a smooth muscle cell, right? Inside the smooth muscle, because of the action of NO, that will activate one interesting enzyme called as guanyl cyclase. What is the name of the enzyme? Repeat, everybody. Guanyl cyclase. So once the guanyl cyclase is formed, once the guanyl cyclase is activated, this will do an interesting work. What it will do? It will convert your GTP, guanosine triphosphate. Guanosine triphosphate will get converted into something called as cyclic GMP, cyclic GMP. Okay. Now this CGMP, my dear students, what will happen? It is the one which will go and cause, vasodilation, cause the vasodilation. So this is the story of your, what is that? That is your mechanism of nitrates, how they're causing vasodilation. Okay. So let's see. I'm just looking at the comments. Okay, great. Very, very great. Very great. Welcome to our live. So let's continue. That is your vasodilation. So if vasodilation has occurred, now we are going to get one question. What is that? Sir, now only you told vasodilation is not the main mechanism, but you are explaining about vasodilation. So listen to me here. How exactly organonitrates have high affinity. Their first action is on the veins. Where will they act? On the veins. Okay, if they're acting on the veins, why? Because organonitrates first effect always seen on the veins, because they have more affinity towards the veins. So if they act on the vein, what will happen? They will cause venodilation. What will happen? Venodilation. So if there is a venodilation, the question comes to us, sir, veins are dilated, what is the use for us in angina? Remember, when veins are dilated, the amount of blood which is coming back to the heart will be reduced. The amount of blood coming back to the heart will be reduced. So that will do what? Decrease of venous return. Decrease of venous return. If venous return is reduced, what will be the advantage for us? Yes, the advantage is the amount of blood coming back to the heart is reduced. If the amount of blood which is coming back to the heart is reduced, automatically that will decrease the preload. That will decrease the preload. If preload is reduced, then the question comes to us, what will happen? So heart was doing more work, it was asking for more oxygen. Even you, if you do more work, you'll ask for more result, right? Like that only, your heart is working more, automatically your heart was demanding more oxygen. Now suddenly what happened? You decrease the preload, you decrease the load on the heart. So now now your, what will your heart do? So automatically your heart has to work less. If heart has to work less, that will decrease the angina symptoms, because that will decrease the demand. So preload will decrease. If preload is reduced, that will decrease what is that? Force of contraction. If force of contraction is decreased, that will decrease the O2 demand. O2 demand. So the first and most important myth which many students had, and I want to clear, what is that? Nitrates causes relief of chest pain by decreasing the oxygen demand to the heart. By doing what? By doing preload reduction. Preload reduction. So that is the first effect. The second effect, their second effect is on your arteries, my dear students. What will happen? It will act on the arteries. If it acts on the arteries, now what will happen? All the arteries will be, all the arteries will also undergo vasodilation. So dilate the arteries. Dilate the artery. If arteries are dilated, automatically that will decrease the afterload. That will decrease the afterload. So I'll tell you one more simple technique to remember. So veins will determine preload and arteries will determine afterload. A for artery, A for afterload. You remember one of them, other one will be effect of the veins. So this is a very small, easy technique for you to remember. So if there is a decrease of afterload, now heart has to work more or less. Yes, heart will also have to work less. Decrease the load on the heart. It will decrease the load on the heart. So if it will decrease the load on the heart, automatically that will decrease the O2 demand. That will decrease the O2 demand, because your heart can pump the blood very easily if the arteries are dilated, sir. So this is a story of your arterial dilation and venous dilation with respect to what? With respect to your angina. With respect to your angina. So then let's continue the third effect. Where will be the third effect? The third effect, my dear students, you can see it majorly coronary dilation. The third effect is on the coronary vasodilation. Coronary vasodilation. Okay, so all of you remember, all of you need to remember one thing, that is the nitrates reduce the chest pain by most important mechanism. What is that? Yes, by reduction of preload. Reduction of preload. So this is the effect of nitrates on the heart. So whenever we are speaking about nitrates, we understood the effect. Okay, understood. So now let's talk about the uses of nitrates. right? Uses of nitrates and how do we give these drugs also. This is also becoming a very popular concept which is being tested repeatedly. So users, they're used in the angina. Yes, of course. So angina means three types of angina. That is your, yes, very good, stable, unstable, and variant angina. In all the three cases, what can be used? Nitrates can be used. Apart from that, nitrates also used in the treatment of myocardial infraction. Myocardial infraction, yes, we can use them in the treatment of achalasia cardia. Achalasia cardia. Now, what is achalasia cardia? The lower esophageal sphincter is contracted. So to relax the lower esophageal sphincter, since they will relax the smooth muscle, we can use which drugs? Nitrates. We can use which drugs? Nitrates. So that is your achalasia cardia. Apart from achalasia cardia, where else we can use them? They're used in the cyanide poisoning. What is that? Cyanide poisoning. Now we people are going to have, what is that? Cyanide poisoning. The question is, sir, how will they useful in cyanide poisoning? So let's understand in the cyanide poisoning, my dear students, how they're used. So whenever, first what we are going to do, a patient had in, what is the treatment, the step by step, and let's understand how they work actually. So normally cyanide is there. Okay, cyanide is there. All right. Now what I'll do, if to these people I will give sodium nitrate. I will give, what is that? Sodium nitrate. So they have taken the cyanide, sodium nitrate. Sodium nitrate, as soon as I give the sodium nitrate, my hemoglobin, whatever is there, right, that hemoglobin will get converted to something called as methemoglobin. What is that called as? Methemoglobin. So whenever you give nitrates, you will get, what is that? Methemoglobin. Now this methemoglobin has more affinity towards the cyanide. Means normally cyanide was trying to bind with the hemoglobin, but also it acts upon, where is that? Yes, majorly it acts upon the cytochrome enzymes, and especially majorly you are looking at electron transport chain. Cyanide is acting upon the electron transport chain. Now what I did, methemoglobin. This methemoglobin fellow, he will not let it go to the cells and act upon, what is that? Act upon your electron transport chain. Rather, methemoglobin will be like, oh my god, cyanide, come, let's get married. So what it will do? It will call cyanide. Yes, it will take up all the cyanide. Methemoglobin plus cyanide are combined. Once methemoglobin and cyanide, they are combined, what will be there? So the next drug we are going to introduce here, that is only called as sodium thiosulfate. Sodium thiosulfate. So as soon as I give sodium thiosulfate, what will happen? It will create a thiocyanate. It will create thiocyanate. Okay, so thiocyanate, later it will go into the urine. Later it will go into the urine. So now what happened? Sodium, first it was called by hemoglobin. Both of them were close together. Then I added sodium thiosulfate. Now it will form thiocyanate plus methemoglobin. Now we can treat the methemoglobin, or it can become normal again. So patient will be out of danger. So that is how we are using cyanides in the treatment of very important cyanides in the nitrates in the treatment of cyanide poisoning. So these are few important uses of your, what is that? Of your organonitrates. Okay. So when we are speaking of organonitrates, now in the angina patient, how we are going to give angina patient? So for angina, remember 1.5 mg, my dear students. 1.5 mg of, what is that? Nitroglycerin. 1.5 mg of nitroglycerin usually used to dose. So what exactly is this? It can be used up to 3 doses. We can use up to 3 doses before, self administering also. We can give 1.5 mg of organonitrate NTG, that is up to 3 doses. Up to 3 doses. Now you are going to ask, sir, first dose I gave, pain did not reduce. Second dose I'm giving, pain did not reduce. Third dose also I'm giving. Sir, how long should I wait for giving one dose to another dose? The duration which you must wait within 5 minutes, with 5 minutes interval, with the 5 minutes interval. Okay, 5 minutes interval. So one dose to another dose, you have to wait only 5 minutes. That is also how we were giving it is sublingual. How we were giving? Sublingual. How we were giving is sublingual administration. So this is the use of nitroglycerin in angina. Okay. Now once we understood about the next important point which I want to discuss regarding nitrates, my dears, is, see, nitrates will have some side effects. So let's talk about the side effects. So the first and most important side effect of these nitrates. So all of you will tell me, so nausea, vomiting, headache. That used to be your common answer for all the side effect. Now remember, the most specific side effect for nitrates is your headache actually. Okay, what is that? Headache. Apart from headache, what else can occur? See, these are a venodilators. If there are venodilators, they will activate which system? Yes, sympathetic nervous system. That can lead to increase of heart rate, increase of heart rate. Then it can lead to flushing. It can lead to flushing. Okay. Apart from flushing, what else it will lead to? Apart from flushing, headache. Okay, flushing, agreed. Apart from flushing, it will cause one of the most important thing which you need to remember, which we already discussed. They will cause methemoglobinemia. Methemoglobinemia. Okay, methemoglobinemia. Along with methemoglobinemia, we have some disadvantages with this drug. These drugs will develop tolerance very easily. Okay, tolerance very easily. Tolerance can develop very quickly and easily. That can also occur. So repeated administration, we have to be very careful. So once we understood about these organonitrates, I want you to go understand this, not just this much, but remember these nitrates can show withdrawal effect. Yes, you might be thinking, sir, withdrawal effect is seen for, like, for example, clonidine antihypertensive, or for example for drugs like some morphine or some opioids, right? How will this cause? Yes, it will show withdrawal. Especially how it will show withdrawal is, yes, they will show withdrawal. How exactly? So once the patient stops using of nitrates, the frequency of anginal attacks will increase. So for example, imagine my patient was having 2 episodes per day he was getting angina. So once he was getting 2 episodes per day, I started nitroglycerin for him. He was using this nitroglycerin continuously for at least 1 year. After 1 year, he decided to stop. So he stopped after 1 year. Once he stopped after 1 year, then he will end up having 4 episodes per day. Okay. So now compare what happened. From 2 episodes a day, it has changed into 4 episodes a day. After stopping of what? After stopping of organonitrates. So that is the most important key point which everyone must remember. They can cause the withdrawal by increasing the frequency of anginal attacks. Okay. So this is a story of your withdrawal of nitrates. Once we understood about withdrawal of nitrates, let's continue into the next important concept, that is your calcium channel blockers. What is that? Calcium channel blockers. What is that? Calcium channel blockers. So now remember, calcium channel blockers, we can use many calcium channel blockers can be used. So are these calcium channel blocker, all of them are classified into two types. One of them called as a dihydropyridines. Okay, along with dihydropyridines, we have non-dihydropyridines. Okay, non-dihydropyridines. Okay, sir, non-dihydropyridines and the dihydropyridines, what is it? See, if any calcium channel blocker, if it is coming from this chemical called as dihydropyridine, we'll put it under this classification. Apart from that, if any other chemical they're coming, then we'll call it as a non-dihydropyridines. Okay, so in this non-dihydropyridines, we have drugs such as verapamil. What is that? Verapamil. And we have one more drug called as diltiazem. What is that? Diltiazem. Okay. Now in dihydropyridines, we have many drugs such as amlodipine. What is that? Amlodipine, nifedipine. Okay, amlodipine, nifedipine, and you have nicardipine. So all of the drugs are there. Now the question comes to us, sir, how exactly dihydropyridines are non? So dihydropyridines, my dear students, act only on the smooth muscle. Remember, they act only on the smooth muscle. So smooth muscles will have which type of calcium channels? So L-type calcium channel blockers act only. Sorry, these dihydropyridine calcium channel blocker act only on the smooth muscle, specifically on the L-type calcium channel. L-type calcium channel. So if L-type calcium channels are blocked, okay, that will lead to decrease of calcium, because see, when dihydropyridines are given, we'll go and block the calcium channel. So once calcium channel are blocked, so decrease of calcium entry. Yes, decrease of calcium entry. Where calcium entry is reduced, inside the cell. So calcium is coming less into the cell. So decrease entry of calcium. If there is a decreased entry of calcium, that will cause vasodilation. That will cause vasodilation. Since they will cause vasodilation, dihydropyridines, remember, they can cause one of the most important side effect. What is that side effect? Remember, vasodilation, BP will reduce. Yes, that will cause a increase of heart rate called as reflex tachycardia. Reflex tachycardia. But you might be asking me, sir, then why are you giving it in angina? We can consider these drugs in angina because they're causing vasodilation and decreasing the preload. Okay, so reflex tachycardia. What is that? Reflex tachycardia can be a side effect associated with these drugs. Okay, apart from reflex tachycardia, what else can be there? So please understand, I will talk about other side effects eventually. First, let's talk about non-dihydropyridine. Non-dihydropyridine act where exactly? On the heart also? Yes, sir, of course. And also on the smooth muscle. Act on the heart and smooth muscle. But remember one important point. These diltiazem and verapamil, they block the calcium channels on the heart as well as this thing. But one important key point, what you must remember, please understand, they do not no significant change of heart rate. No significant change of heart rate, specifically by due to what? By due to that's a reflex tachycardia. No significant change of heart rate due to reflex tachycardia. Reflex tachycardia. Okay, so that is the most important key point which everyone must remember. Now, diltiazem and verapamil, where can we use, sir? We can use them in angina. Amlodipine also, like amlodipine, nifedipine also used in angina. But we need to understand amlodipine and nifedipine, they can also be used in the treatment of hypertension, for example. Okay, so other conditions also we can consider them. So they relax the smooth muscle. I'll tell about antihypertensive property with the hypertension. Okay, now once we understood about this, then let's continue to the next important point. What is the next important point? Beta blockers. What is that? Beta blockers. Okay, beta blockers. Now, before going to beta blockers, recently I noticed this question which is being asked. So I just want to tell you people, remember this. Okay, this diltiazem and verapamil, they have negative effect. Negative which effect? Remember, negative ionotropic effect. Negative ionotropic effect. Okay, they are also having negative chronotropic effect. Negative chronotropic effect. Okay, and also negative dromotropic. Okay, so all the effects will be negative as a result of what is that? Calcium channel blockers. So that is why the reason why we can use them in the angina, that is also one of the main important reason. Okay, so let's go to the next important, beta blockers. When we are speaking of beta blockers, so beta blockers, cardio selective are better used. Which ones are used? Cardio selective are better used. Cardio selective are better. Why cardio selective are better? Because we will not have a side effects due to what is that? Due to the blockage of beta 2 receptor. So cardio selective beta blockers such as atenolol, metoprolol. Okay. For example, you have you have your esmolol. Okay, esmolol. Right. Now, sir, how to remember which is cardio-selective beta blocker, which is non-selective, which is beta 1 and beta 2 blocking beta blocker. So the technique is very simple. Any beta blocker, if their name is starting with the letters of A, right? B, C, D, E, F, G, H, I, J, K, L, M. So if their names are starting from here to here, A to M, they are high likely they are beta 1 selective blocker, beta 1 selective blockers, beta 1 selective blockers. Now remember, if any drug's name is starting from N and ending with Z, so they are usually beta 1 and beta 2 blockers. So beta 1 and beta 2 blocker. This is one technique with which you can remember what is that beta blocker. So how will the beta blockers act? They will act by reducing, they will decrease the force of contraction of the heart. They will decrease the force of contraction of the heart. So once we understood about this anti-anginal drugs, now there are some cases. So remember there is one important thing. What is that? For the treatment of angina, we use which drugs? I agree with you people, mostly used ones are nitrates. Sir, what else we need to remember? So the combinations, what we can use? CCBs, okay, beta blockers, CCBs, beta blockers, and nitrates, and nitrates. So all these three things can be used for your angina. So that is your stable angina and unstable angina. Sir, but for variant angina, usually prefer drugs either CCBs or nitrates only. We don't use which ones? Yes, that is your beta blockers in which angina? For the variant angina. For variant angina which is not used, yes, the CCBs and beta block CCBs and nitrates are used. Beta blockers are not used. So that is the story of your combinations. And one more thing, now many people would have studied, sir, we do not combine beta blockers with calcium channel blocker, right? So you need to understand, for the highly resistant cases, actually we combine CCBs, okay, plus beta blockers, and also, my dear students, plus nitrates. So all three of them are used for what is that? Resistant form of angina. So for example, you give one drug and if that is not responding, yes, that is definitely what is that? Organonitrates with beta blocker and calcium channel blocker if they are not responding to single drug. So the next important question comes to us, sir, nitrates, is there any drug interaction? Remember, my dear students, yes, nitrates will cause interact with one important drugs, that is your PDE5 inhibitor, interact with the PDE5 inhibitor. So what are those PDE5 inhibitor? Such as your, what is that? Sildenafil. Where do we use sildenafil? Tell me, where do we use sildenafil? Sildenafil is used for the treatment of erectile dysfunction, not for premature ejaculation. It is used for the treatment of erectile dysfunction. Now, what happens? Remember, these PD5 inhibitors also have a vasodilatory effect, and your nitrate also has a vasodilatory effect. So, if any person comes to you, and this is a very commonly asked question also, see, the patient will come to you and they'll be like, Dr. Saab, एक डाउट पूछना, एक डाउट. So definitely this is the tone they'll start, and they'll tell you what, नहीं actually ना थोड़ा personal. Okay, what is it? Tell man. Okay, don't eat my head now. Tell me what is it. They'll ask actually sildenafil, वो जो Viagra होता है ना, Viagra. So what can I take Viagra if I am getting the medication? So they will be coming to you for some other problem. They will ask, can I combine sildenafil with these things? Is it safe or unsafe? Remember, make sure to tell your patient, if you are going to use nitrates, never combine them with the sildenafil. Now, if they are going to use the nitrate, we should advise the patient usually to avoid sildenafil. Rather sometimes we can decrease the dose and use, but they will always have a risk of developing hypotension. So for the patients with your, what is that, organonitrates usage, please advise them not to use PDE5 inhibitor. This is a quite common thing, okay? And this is a commonly asked MCQ as well. So please pay attention. They interact with the PDE5 inhibitors. Okay. So now once we understood about PDE5 inhibitor, so we have other drugs such as, first write down. So let's start with the nicorandil. What is that? Nicorandil. Okay, what is this Nicorandil will do? Nicorandil will open the potassium channel. Open up which channel? ATP sensitive potassium channel. ATP sensitive potassium channel, specifically on the heart. So they will open what? ATP sensitive potassium channel. So if they are opening the ATP sensitive potassium channels, open the ATP sensitive potassium channels. If they open the ATP sensitive potassium channel, that will lead to what? That will lead to opening of the potassium channel, that will cause hyperpolarization of the cell. Hyperpolarization of the cell. So that is the mechanism of your, what is that? Nicorandil. Okay. Apart from Nicorandil, we have one more drug called as Fascudil. What is that called as? Fascudil. So this Fascudil, my dear students, this is a type of an enzyme is there called as Rho kinase. What is the name of the enzyme? Rho kinase. What is the name of the enzyme? Rho kinase. So Fascudil is a Rho kinase inhibitor. Rho kinase inhibitor. Okay. Then, my dear students, we have one more drug, that is your trimetazidine. What is that? Trimetazidine. Okay. So what is this trimetazidine? So I want your attention to be paid here. So trimetazidine is the drug which will inhibit, yes, it will inhibit fatty oxidation. It will inhibit, what is that? Fatty oxidation in the heart. So usually in the heart, what is that? Fatty oxidation. So that too, it will inhibit partially, actually. Okay, partially inhibit fatty oxidation. So if partially, if it is inhibiting the fatty oxidation, that will be giving us what exactly advantage? Remember, partially if the fatty oxidation is inhibited, so that will lead to what? So fatty oxidation is inhibited. Inhibition of fatty oxidation will create, what is that? Decrease of O2 demand. Why there will decrease of O2 demand? The answer is very simple, my dear students. The decrease of O2 demand, the decrease of O2 demand is because fatty oxidation requires more oxygen. Remember, for example, carbohydrates and also your fats. So fats require more oxygen, carbohydrate require less oxygen. So if I stop the oxidation of fats, my heart will utilize more of carbohydrates. That time, by that will require less amount of oxygen. Okay. So this is the story of your angina. This is the story of your angina. So once we understood the story of angina, let's go to the next important, and that is your hypertension. What is that? Hypertension. So hypertension, we already discussed about the many of the drugs which will come in hypertension, but here we are going to learn with respect to blood pressure. Okay, let's start with the first and most important, hypertension. So hypertension, my dear students, we follow right now, the guidelines followed is JNC guidelines. Okay, JNC 2011 guidelines usually follow. Okay, so usually the followed is JNC guidelines. Okay, so what is this? The Joint National Committee of United States will give the guidelines related to hypertension. So how exactly they are classifying the hypertension now? Okay, so remember, if the systolic, if the systolic, okay, so if it is 140 to 169, till what? 140 to 169. So this stage of hypertension, we will call it as a mild and diastolic being. Yes, this is also very important, right? So diastolic from 90 to 99. Okay, 90 to 99. So if we are going to call it as moderate, okay, moderate, yes, you need to understand. So that is your mild hypertension. Moderate is from 170 to 179. 170 to 179. So this is more severe, more than how much? More than or equal to 180. So you can even mild, moderate. Let's remove that also. I'll give you best idea. So this is your stage 1 hypertension. Stage 1 hypertension. This is your stage 2 hypertension. Stage 2 hypertension. And this one will be called as severe hypertension. So here from 100 to 110. Okay, so here 100 to 109 actually. So more than or equal to 110 will be called as severe hypertension. So this is a diastolic and systolic blood pressure. So, my dear students, the drugs used in the hypertension, we need to understand. So, to understand the drugs used in hypertension, what are the drugs which are called as first line antihypertensive drugs? So, to understand first line antihypertensive drug, first we need to know the names or groups of the first line antihypertensives, right? So, when we are speaking of first line antihypertensive drugs, let's understand we have four groups of drugs which you must remember. That is your calcium channel blockers. Which ones? Calcium channel blockers. Then we have ARPs. Yesterday we discussed actually angiotensin receptor blockers. Then also we have one more thing, ACE inhibitors. What is that called as? ACE inhibitor. And the most important, that is your thiazides. That is your thiazides. So these are the four groups of major antihypertensives we have. But to understand about the other antihypertensives and these drugs, first we need to know how your body will respond if there is a reduction in the BP. So by understanding that mechanism only, we will be able to understand the rest of the hypertension related. So what is that? Whenever there is a, if there is a reduction in BP, reduction in what? BP. So imagine, for example, there is some cut wound or bleeding wound, internal, external bleeding. So during all those times, what is going to happen, my dear? Decrease of BP. As soon as there is a decrease of BP, how exactly your body will respond? There is a decrease of BP, that will decrease the cardiac output. That will decrease the cardiac output. Right? So if there is a decrease of cardiac output, that will activate which nervous system? Yes, a sympathetic nervous system. Sympathetic nervous system. So if sympathetic nervous system is activated, this sympathetic nervous system will activate which receptor? Alpha 1 receptor. Alpha 1 receptor, they are located where? In the blood vessel. So what will happen? There will be vasoconstriction. If there is a vasoconstriction, that will lead to increase of BP. That will lead to increase of BP. One mechanism. But this sympathetic activation, my dear students, will also activate one more receptor called as a beta 1 receptor. Beta 1 receptor. So this beta 1 receptor will cause increase of cardiac output. That will also increase the blood pressure. Yes. But there is still more which is occurring. If there is a decrease of BP, if there is a decrease of BP, automatically there is a decrease of renal blood flow. Renal blood flow. Yes, decrease of renal blood flow. So if there is a decrease of renal blood flow, or if there is an activation of beta 1 receptor, remember beta 1 is not located only in the heart but also located in the kidneys, especially in the RAS system, that is your especially in the JJ apparatus. So this renal blood flow decrease and beta 1 activation, they will cause renin release. They will cause what release? Renin release. So this renin, whatever is released, will convert your angiotensin 1 angiotensin 1 angiotensinogen. Yes, angiotensinogen will get converted into angiotensin 1. Angiotensin 1. So this angiotensin 1 will get converted into angiotensin 2. Angiotensin 2. So this angiotensin 1 to 2 conversion, angiotensin 2. So this conversion requires one enzyme. That is your very good enzyme, very good answer. ACE. What is that? Angiotensin converting enzyme. So this angiotensin 2, my dear students, will cause vasoconstriction by doing what? They will, angiotensin 2 will go and stimulate something called as AT1 receptor. They will stimulate something called as AT1 receptor. So stimulation of AT1 receptor will cause vasoconstriction, that will lead to increase of blood pressure. So this is one mechanism. And also this angiotensin 2 will go and activate the formation of your aldosterone. Activate the formation of aldosterone. So that will cause increase of sodium and water in the body. If because of increase of sodium and water, they will cause, what is that? Yes, increase of sodium and water, that will lead to increased amount of circulating volume, which will lead to increase of blood pressure. So this is a mechanism how your body will respond to, what is that? Yes, decrease of BP. So why one must know? Just imagine now, if you want to treat somebody with hypertension, simple block beta 1 receptor. Sorry, alpha 1, or block beta 1 receptor, or block AT1 receptor, or block ACE, or block renin, or you can block, what is that? Yes, vasoconstriction. You can cause the sodium and water to go out of the body. So you can do any of these things and treat the hypertension, okay. So once we are speaking about hypertension, let's talk about the first group of antihypertensive drugs, that is your diuretics. Okay, so what are the diuretics which are used as a antihypertensive? So diuretics which are used as a antihypertensive drug, mostly your thiazides, and also we can use one more group is there, that is your potassium sparing diuretics also can be considered. So thiazides is used. Now when we are speaking of thiazides, what is the mechanism of action? Yes, one of the most interesting mechanism of action, they will inhibit something called as sodium and chloride pump. They will inhibit, what is that? Sodium and chloride pump in the distal convoluted tubule. Okay, so if sodium and chloride pump is inhibited, very simple. If you consider this is your nephrons distal convoluted tubule, followed by that this was your collecting duct. So here what was happening, sodium and chloride was getting reabsorbed into the bloodstream. Now what will I do? I will make the closure of this reabsorption. So if sodium and chloride is not reabsorbed, all the sodium and chloride will start to go into, what is that? Go into urine. So if sodium and chloride is going to urine, that will inhibit the sodium and chloride. So that will cause the loss of sodium. If sodium is being lost, also it will take water with it, because in the kidney, golden rule is water follows sodium. Water follows what? Sodium. Okay, and also loss of chloride ions will be there, and because of sodium going from the collecting duct, potassium can also be lost. Okay, why? Because collecting duct will try to reabsorb sodium. See, because I blocked the DCT sodium reabsorption, more sodium will come to collecting duct. Initially it will try to reabsorb more of, yes, reabsorb more of, while it is trying to reabsorb more of sodium, it will cause the loss of potassium. So that is a property in collecting duct. Okay, so it will also cause potassium loss also. Okay, now when we are speaking of thiazide diuretics, remember what is the use of these diuretics? Remember thiazides, the first important drugs. So something called as indapamide. What is that? Indapamide. There is one more drug called as a hydrochlorothiazide. Okay. Now hydrochlorothiazide. What is the importance of these drugs? Remember, hydrochlorothiazide is the best among all the thiazide diuretics, because other thiazide diuretics can cause gout. Other thiazide diuretics can lead to, what is that? Gout. Okay. Apart from gout, there can also be one more issue. What is that? That is the, please remember, hypokalemia. But that hypokalemia also avoided. Hypokalemia is also avoided, and also your, what is avoided? Yes, hypokalemia is avoided, and also gout incidence can be avoided with a hydrochlorothiazide. So other thiazides will cause these two side effect. That is one thing. It is the best approved dose is from the 12.5 mg to 25 mg. So this is the best drug. This is the first or drug of choice for management of hypertension. Okay, so drug of choice for the first line drug for the management of drug of choice. So how exactly they will reduce the blood pressure? Yes, how will they reduce the blood pressure? Again, here also there are two reasons. Like nitrates, we had preload and afterload reduction, like that only. Here also we have few reasons. How will they reduce the BP? How will they reduce? Initially they will cause loss of, what is that? Yes, loss of sodium. If there is a loss of sodium, automatically that will lead to loss of water. So that will lead to decrease of plasma volume. Decrease of plasma volume, that will reduce the BP. Okay, so that will occur when? Initially. That will occur when? Initially. But as the time passes, so what can happen? The fluid volume actually can come back to normal. Though sodium is lost, fluid volume can come back to normal. So since the fluid volume can come back to normal, then what here we need to understand? So later the important aspect, later they will work by reduction of peripheral vascular resistance. How are they working? By reduction of peripheral vascular resistance. So initially by decreasing the by decreasing the plasma volume, later by decreasing the peripheral vascular resistance. So that is how they are decreasing the blood pressure. So if peripheral vascular resistance is decreased, how exactly it will decrease? Due to decrease of sodium. So remember, if less of sodium, if there is a less amount of sodium, that will actually decrease the elasticity of the blood vessel. So that is the mechanism with which what is occurring, BP is being reduced. So this is about the story of your thiazides. But thiazides can cause gout. Thiazides can cause gout, but among all the thiazides, the best one is, what is that? The best one is hydrochlorothiazide. Yes, they can also cause a hypokalemia, hypochloremia, hyponatremia. Of course, they can also affect the blood glucose, alter the blood glucose level. So these are some side effects associated with your thiazide diuretics. So sir, what will be the question for me? The question you are going to encounter, you can encounter about the peripheral vascular resistance. How will the thiazide reduce the blood pressure? They will decrease by two mechanisms. Okay. So that is the story of your thiazides with respect to hypertension. Now, once we understood about thiazides with respect to hypertension, let's continue to the next important aspect. What is the next important aspect? We also have ACE inhibitor. My dear students, ACE inhibitor, yesterday also we have discussed. Once again I will tell, they will inhibit one enzyme called as angiotensin converting enzyme, that will lead to reduction of angiotensin 2 angiotensin 2. If they are reducing angiotensin 2, automatically it will cause, what is that? Decrease of peripheral vascular resistance. But one important, if there is a decrease of peripheral vascular resistance, they also, one more advantage is there, they do not cause reflex tachycardia. So all the vasodilators usually was causing, what is that? Yes, that was your reflex tachycardia. But these drugs do not cause reflex tachycardia. Only they will decrease the blood pressure. This will be the advantage. The AC inhibitors, which we have discussed already, we have such drugs such as captopril. Okay, we have lisinopril. Okay, we have enalapril. Okay, enalapril. So all the prils are your ACE inhibitor. Now, whenever we use ACE inhibitor, automatically bradykinin breakdown will not occur. They can cause the side effect, remember, they can cause increase of potassium level, hyperkalemia. Okay, then dry cough. What is that? Dry cough. Okay, remember they are teratogenic drugs. This was a previously asked question. They are teratogenic drugs. They are never going to be used in which condition? Yes, they are never be used in pregnancy, because they can cause teratogenicity. Dry cough will be there, and also they increase the possibility of angioedema. Okay, so these are the important side effects associated with, what is that? That is your ACE inhibitors in the with respect to hypertension. Now, one important aspect, other uses of AC inhibitor. Yes, other uses of AC inhibitor are congestive cardiac failure. Yes, the hypertension, of course. Okay, uses. And also we can use them in the diabetic nephropathy. So that is the story of your ACE inhibitors with respect to hypertension. Then let's talk about ARBs. Now ARBs, already we know they're going to block which receptor? Yes, AT1 receptor. Which receptor? AT1 receptors. So if AT1 receptors are blocked, they will also decrease the peripheral vascular resistance. That will decrease the blood pressure. So ARBs are superior than, yes, they are superior to whom? Superior than, yes, than your, what is that? ACE inhibitor, because ACE inhibitor can cause side effects such as your very important dry cough and also angioedema. See, this happens coincidentally, right? So this is about your, what is that? ARBs. Now, once we understood about ARBs, let's write down the names of the drugs. All of them ends with sartans. They are your sartans. Which are those sartans? losartan. What is that? Losartan. Okay. We have drugs such as valsartan. What is that? Valsartan. Okay. So we have drugs such as telmisartan. So these drugs are better used. Now remember one of the most interesting aspect, these drugs, both of these drugs can have aldosterone escape, one thing. Okay. And remember, ACE inhibitor and also your ARBs. There are some facts about these drugs which you must remember. Okay. So both of these drugs are useless, less effective in, yes, less effective in which type of hypertension? So remember, they're less effective in low renin hypertension. Which hypertension? Low renin hypertension. So there are two types: high renin hypertension and there is a low renin hypertension. If there is a low renin hypertension, then AC inhibitors and ARBs are less effective, right? And also these are not used, especially AC inhibitor, not used in bilateral renal artery stenosis. Bilateral renal artery stenosis also we try to avoid these drugs. Okay. So this is the story of your AC inhibitor and ARBs. Now please understand, my dear students, AC inhibitor and ARBs, they're very good drugs. I agree with you people, but only problem is what is that? Less effective in low renin hypertension and also not used in pregnancy, we can do. Now once we understood about this, let's talk about calcium channel blockers. Calcium channel blockers. So calcium channel blockers, we mainly used ones are dihydropyridines. Dihydropyridines. So when we are speaking of dihydropyridines, I want you people to understand some important concept here. These dihydropyridines, they block L-type calcium channel. They block which channel? L-type calcium channel on your blood vessel. On your which vessel? Blood vessel. So because of that, decreased calcium entry, decrease of calcium entry. If there is a reduced calcium entry, that will cause vasodilation. Vasodilation, that is reducing the blood pressure. We have drugs such as amlodipine. Okay. Then we have one more drug called as nifedipine. What is that? Nifedipine. Okay. Then we have one more drug called as S-amlodipine. S-amlodipine. Okay. So there are so many drugs are there. All of them are ending with what is that? Dipines only. We have one more drug called as nicardipine. What is that? Nicardipine. That is also the drug which can be used in the treatment of hypertension. Now, when we are speaking of dihydropyridines, first let's understand the uses of this drug. Where can we use them? Uses of the drugs. So when I'm speaking about the uses of dihydropyridines, remember one of the most important, all of us know, hypertension. We also use them in angina. So apart from these two, where else we can use them? We can use them in the congestive cardiac failure. We can consider them in the congestive cardiac failure, but not so great first line drugs. Okay. Then also, my dear students, so also these calcium channel blockers are used in the smooth, because they will relax all the smooth muscle, not just only your what is that? Yes, not just only your that is the smooth muscles of the blood vessel, but also smooth muscles in other places. So this can be used in achalasia cardia. So this is a story of your what is that? Calcium channel blockers. So once we understood about these four groups of drugs, now I want to talk to you people about other antihypertensive drugs. And one thing, that is next thing is some special some other conditions with hypertension, means patient has some other disease, along with that there is hypertension. So what are the best drugs we can use them, and what and all the important MCQ point of views in the hypertension, let's understand. The first and most important, we have something called beta blockers. So beta blockers, one of the most important concepts which are clinically related. Beta blockers, they will block beta 1 receptor. If they block the beta 1 receptor, automatically they will decrease the renin release. So if there is a decrease of renin release, the keyword is here, decrease the renin release, automatically RAS system will not get activated. That will decrease the blood pressure. So where we can use them? A patient, if they are having a previous history of MI, history of myocardial infarction and hypertension, the best drugs you can use them is beta blocker. Which drugs you can use them? Myocardial hypertension, myocardial infarction and hypertension. Now beta blockers, beta 1 selective blocker. Then we have alpha plus beta, alpha and beta blocker, alpha and beta blocker, alpha and beta blocker. We have a drug called as labetalol. There is a drug called labetalol. So along with this labetalol, there are other drugs such as the hydralazine. What is that? Hydralazine. And there is one more drug called as alpha methyl dopa. We have one more drug called as alpha methyl dopa. Alpha methyl dopa. Okay, alpha methyl dopa. So alpha methyl dopa and hydralazine, they can be used in the, all three of them are safe in pregnancy. All three of them are safe in pregnant female with a hypertension. They're safe with where? Pregnant female with a hypertension. So this is a very, very, very important point to be remembered. Sir, how will our hydralazine work, sir? Hydralazine, my dear students, it is actually potassium channel opener. It is, what is that? Potassium channel opener. Okay. Alpha methyl dopa, actually it is a centrally acting drug. It is a centrally acting alpha 2 agonist. It will stimulate the alpha 2 receptor that will be used in the treatment of hypertension. We have centrally acting alpha 2 agonist. We have another drug centrally acting alpha 2 agonist, clonidine, but which is not safe in pregnancy. Which is not safe in pregnancy. The safe drugs in pregnancy is three drugs: labetalol, alpha methyl dopa and hydralazine. Then we will get one more question. For example, what is there? If there is a alpha blockers, yes, alpha blockers, specifically we are using is alpha 1 blockers, alpha 1 blockers, alpha 1 blockers such as your prazosin, such as your prazosin. So prazosin and alfuzosin, alfuzosin. So these prazosin and alfuzosin are chosen in patients with benign prostatic hyperplasia and hypertension. This is also a very, very frequently asked question. What is that? Alpha blockers are used in BPH with hypertension patient, benign prostatic hyperplasia with hypertension patients. Okay, so that is your alpha blocker. Sir, why BPH patient? Because see, urinary symptoms can also be improved by your alpha blocker, since alpha receptors are located in the urinary bladder sphincter. So the patient will have difficulty in urination. By giving alpha 1 blocker, we will improvise the symptoms of difficulty in urination, and also we are going to decrease the blood pressure. That is the story of your, what is that? Alpha blockers with respect to the hypertension. And one more advantage, they decrease the triglycerides. They can ask you which antihypertensives decrease the triglycerides and also decrease the low density lipoprotein, and they will increase the HDL. So they have a positive effect on the blood cholesterol, good effect on the blood cholesterol. That is a very good advantage with the alpha blocker. Now once we understood about this, many students will ask me, sir, what if patient with diabetes mellitus and hypertension, what is the best drug in this case scenario? Hypertension with diabetes mellitus, remember, best are ARBs. If ARBs are not there, then your ACE inhibitor, that is with respect to exam. If you are speaking of what is that clinical practice, I would always suggest you what is that ARBs, because they have a better advantages. Okay, now, any other drugs, sir? Any other conditions? Yes. I want you people to understand, a patient who is having hypertension with the gout, hypertension with the gout, the better used drug is losartan. What is a better used drug? Losartan, since it is having uricosuric effect. It is having uricosuric effect. So that is why we can use which drug? Losartan. Which drug can be used? Losartan can be used. So this is some special conditions along with hypertension associated. Okay. Then I want you to understand the next important hypertensive emergency. What is that? Hypertensive emergency, and what is the urgency, and what are the drugs used. Okay, so hypertensive emergency, in both of these conditions BP is almost equal to 100 or 180, more than or equal to 180. Okay, the main differentiating factor here is that there is no end, there is a presence of end organ damage with hypertensive emergency. In the hypertensive urgency, no organ damage. Remember, end organ damage. What is that? End organ damage. End organ damage. So when I'm speaking of end organ damage that occurs with the hypertensive emergency, here no organ damage. That is the difference. Okay, sir, if there is an organ damage, what type of damages can we encounter? Remember the damages which we can encounter, such as hemorrhagic stroke. What is that? Hemorrhagic stroke. Okay, patient can have suddenly, what is that? Retinal hemorrhage. What is that? Retinal hemorrhage. Okay, retinal hemorrhage. Why? Because there was a increase of the blood pressure. So now if you look, small blood vessels are ending in the retina, right? So there are the end arteries. Wherever the blood vessels are ending in that areas, they're small and they can rupture very easily because of the high blood pressure. So they can cause a retinal hemorrhage. Along with the retinal hemorrhage, what else can we encounter? So remember, the next important aspect is your aortic dissection. What is that? Aortic dissection. Okay, aortic dissection. Aortic dissection. So these are some end organ damages. Along with that, the patient can have acute left ventricular failure. Acute left ventricular failure can also be associated. Okay, so these are the end organ damages. So whenever patient comes to you with emergency and urgency, what are the drugs used? So drug of choice for hypertensive urgency and emergency, specifically hypertensive emergency, that is your IV nicardipine. IV nicardipine. Okay, so that is said by our textbooks. So textbooks say what is that? IV nicardipine. Okay, thank you so much. I'm just seeing your messages right now. Yes, FMG, you asked a question. I just saw your comment. So, if only more than 100 diastolic is there, that is also called as hypertension, of course. Okay. Yes, IV nicardipine, but usually we will not have IV nicardipine available. So, if IV nicardipine is not there, then we can go for drugs such as labetalol. We can use the labetalol. So, theoretically speaking, the best drug is always IV nicardipine. But can we use any other drugs? Yes, we can use. We can use labetalol. We can also use esmolol. Esmolol is a short-acting and fast-acting beta blocker. Short-acting and a fast acting beta blocker. Then the next important drugs we can consider, we can use is sodium nitroprusside. What is that? Sodium nitroprusside. Sodium nitroprusside. So these are the drugs which can be used. Okay, sodium nitroprusside again used IV. Now some people will ask me, sir, when we are reducing the blood pressure, how much we should reduce? Sir, should we bring from 220 was there, patient was having a BP of 220, should I bring it directly to 110? No, 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 no. Within first few hours, within first 2 to 3 hours, first 2 to 3 hours, about 25 percentage of reduction, 25 percentage reduction is sufficient. Suddenly decreasing the BP is also dangerous. If you suddenly decrease the BP, the main important organs can have a lack of perfusion. If there is a lack of perfusion, that can cause the organ damage. So first 3 hours, first 2 to 3 hours, first 2 to 3 hours, what is the target? Yes, 25% reduction, and up to, you are bringing up to only this level, up to systolic up to 160. You are bringing only systolic up to 160, not below that. Why not below that? If if BP dropped suddenly, what can happen? If BP decrease suddenly, then what you are going to have? If the BP is reduced suddenly, then you are going to have one issue. What is that issue, sir? BP will reduce suddenly. That will decrease the perfusion. That will decrease the perfusion to the vital organs. That will decrease the perfusion to vital organs. So there is a decrease the perfusion to the vital organs. That will lead to, what is that? That will lead to organ damage. So that is why you are not supposed to reduce the blood pressure very suddenly, very suddenly. So this is the story of your, what is that? Story of your hypertension. Hypertension. Clear? Hope everybody understood everything. Okay, so wherever I have told, this was a previously asked question. So for you students who are preparing for FMG and NEET exams, for you people, so these are very, very important questions. And for example, you are preparing as such theory means wherever I said clinically important and whichever points which I have highlighted, they are definitely important for your clinical practice also and also for your what is that exams. Okay, so this is the discussion of your what is that hypertension and angina. Hope everyone enjoyed the session. See you people next time. Thank you. Bye bye.